Hello everyone, Kent.Bressler here. I want to welcome you to Kent's Kidney Stories. During our time together over these podcasts, I'd like to discuss kidney disease. I'd like to tell you about my journey as a transplant patient, but also talk about dialysis, kidney donation, and just about anything else that might be of interest. Kent's Kidney Stories, podcast endorsed and sponsored by kidneysolutions.org.
Hello, everybody. This is Kent.Bressler, and we're back at it. We're going to do some podcasting tonight. I've got a really great guest that I want to talk to a little bit later. So let me say a prayer for us. If everybody could just kind of get in prayer mode. Dear God, I know I'm a sinner and I ask for your forgiveness. I believe Jesus Christ is my son. I believe that he died for my sins and that you raised him to life. I want to trust him as my Savior and follow him as Lord. From this day forward, guide my life and help me to do your will. And I pray this in your name. Amen.
Amen.
So I've got to say to everybody, I hope that all my friends out on the coast of Texas right now are coming out from underneath that category 1 that wasn't supposed to be, that showed up this morning early. I know that my kids are safe, and I just hope that y'all are. And this hurricane season's been kind of difficult. But anyway, blessings to you out there, and make sure that you email me, let me know everybody's okay. I appreciate that. And in the interim, we're going to go on and we're going to have a really enjoyable discussion tonight with my guest, Dr. Velma Scantlebury. Dr. Scantlebury is a transplant surgeon and also an author of Beyond Every Wall, Becoming the First Black Female Transplant Surgeon. She is interested in community education around increasing organ donation and transplantation. She's also a transplant consultant and does a lot of mentoring for increasing diversity and women in surgery. We're very, very happy to have you tonight, Dr. Scantlebury. I hope I'm pronouncing that correct. I can mess it up pretty good. Is that correct?
You're doing a great job. It is fine. Thank you so much.
Thanks for coming in. We're going to do just kind of like we always do on Kent's Kidney Stories, Kidney Solutions. We're just going to have a conversation, and I'm just really interested in kind of picking your brain a little bit. So I hope you don't mind some of my questions. You graduated, I believe you said, from you went school at Pittsburgh, right?
Yeah, I actually did my general surgery. I graduated as far as medical school from Columbia University in New York, did general surgery at Harlem Hospital. And from there, with my interest in transplant and pediatric surgery, actually went out to University of Pittsburgh to do a fellowship in pediatric surgery, but my research was in transplant surgery, and that's how I got hooked into transplantation surgery.
Well, you are on the walk on Clubhouse, and I just fell in love with some of your conversations that you get. You get in there and you tell it like it is, and I'm really amazed, because I've been transplanted for 34 years, and to hear your take on things, it's refreshing. And I also know that you have an interest, like I do, in preemptive transplant.
Absolutely.
And I would really like to hit right off on that start. I mean, tell me a little bit about your feelings about preemptive transplant.
It certainly is the way to go, but that is all built around the fact that someone has to have an early diagnosis. And in order to have an early diagnosis, you have to have adequate follow-up and knowledge of underlying illness with the realization that transplant is the gold standard and the solution. And so when we look at healthcare in this country, we are putting fires out. Preventive care in itself is not what we do. And so we have so many people who are unaware of kidney disease, unaware of chronic kidney disease, unaware of where they're headed. Because as you know, kidney disease is a silent disease. And so it requires monitoring. It requires an understanding of your risks and potential dangers when it comes to your underlying health. So many people I know who are diabetic or have high blood pressure, which are the two leading causes of end-stage kidney disease, are not aware that they could end up on dialysis if their kidneys fail. And so many friends that I get calls from will say, oh, I just came from my doctors and they told me I'm in stage 4. And I goes, how did you get to stage 4 without knowing that you were, what happened to 2 and 3? Was this a sudden discovery, or a light bulb just went off and they're realizing that your kidneys are, that's the realization that, yeah, perhaps somewhere along the line, we need to have better diagnosis, early diagnosis, monitoring. And that's part of one of the things that I applaud Tom Joyner in his morning show was about, take a loved one to the doctor, go with them, because so many times our patients don't understand what's being said to them. Or I go to my hair salon and the lady says, well, my doctor says I have a touch of diabetes. What's a touch of diabetes? That's, to me, that's like being a little bit pregnant. Eventually it might get worse. And so understanding your disease process and what you are at risk for. We know high cholesterol is involved and can lead to heart disease, and we work on that. So knowing that your creatinine is slowly rising or by age or whatever it is important to get to the point where you say, okay, now we're headed down the pipeline. You are at stage 4. Let's think about the choices. Not you may end up on dialysis, or you're going to end up in dialysis in a year. How about discussing the better side of the solution, which is, let's think about transplant. Let's think about where you're going to need a kidney, whether it's in 6 months or a year. That's where planning can really be instituted and getting you in the right path.
What are your markers for early detection? In other words, what are you looking in a patient, or just a general in the community? What are you looking for that will tell them that they have kidney disease? Are there any markers, any tests that they can do?
People, when you go to, I always tell people, if you say know your numbers, I always say when you say know your numbers, also know what your creatinine is. We talk about know your blood pressure, know your cholesterol, know your hemoglobin A1C. Those are all good pointers. But I also want to know, when you get that blood work, also ask yourself, what's my kidney function? What's my creatinine? Do I have protein in the urine? Because protein in the urine may appear sooner than before your creatinine becomes a problem. But that's with the exception of diabetics. Diabetics will have protein in the urine just from the underlying disease process without having underlying kidney issues. So it does make a difference in that solution and from that standpoint. So it is not normal if you're not a diabetic to have protein in your urine. So get it checked. Those are things that we miss, even in childhood. So many times I see kids who had protein in the urine. The doctor sent them to a urologist who says, oh, I got a scan and an ultrasound and your kidneys look fine. So from their standpoint, they're looking at structural abnormalities. And that protein get missed because they said, well, you don't have any stones and your kidneys look fine and you don't have a urine infection. But that's a marker of something that needs to be followed, because in 5 years or so, that child may end up with kidney disease that may be detectable.
And that's an early age too. Teenagers and early 20s. I got diagnosed when I was drafted. I right off the bat with a simple urinalysis. All right.
Right.
I have
Right.
protein in my urine, and that's where you see it is in the urine.
Right. Right.
So do you think that we need more screening for kidney disease?
I definitely think we need more awareness. I think if it's the fact is that for most of us, it's not on our radar. And if you think if you think about it, when I usually tell my students, in order to diagnose TB in a patient who comes in with a cough, you have to think about it has to be on your radar as a potential cause, because it takes a different test for you to be able to send it off. It's not going to come by a blood test. So if so many people go to their doctors and they get blood work, but they don't get a urine and so the blood work would be normal, but nobody checked their urine.
That's been my argument all along. Even sometimes every time you go into the nephrologist's office, that's the first thing you get. They won't even let you in the door till you've done a urine specimen. But in the GP offices in general, they don't do urinalysis.
Yeah, if you say you can't go, they say, okay, we'll do it next time. And next time you forget.
Yeah.
Forget.
Yeah.
Very important.
I think it's extremely important. Now, I don't know. I had heard at one point in time that, Medicare used to pay for all these things in an office visit, and they don't, like for a straight urinalysis. I still think there's somewhere that's really got to be a standard of care in itself, because it picks up kidney disease. It picks up a large majority of kidney disease. Not all the time.
And that's even for the parents my population who I advise and talk to and give talks to, I say, for your children, for your young kids and for your teenagers, the 12 plus, so many times I remember as a parent where the pediatrician, my daughter said, I can't go. And they were like, okay, don't worry about it next time. And I'll be, no, we're going to give her something to drink, and she's going to go dance around, and she's going to come back and give a urine sample.
Yeah.
That's something as a parent, I want you to, if nothing else, make sure that your kids get the urine sample checked.
What percentage of the population, I might be putting you on the spot here a little bit, of children are prone or do have actual kidney disease diagnosed?
It's probably small. It's probably, I don't know the numbers, but I'm going to guess and say it's probably less than 5%.
Okay.
But it's that population that you don't want to miss.
Absolutely.
And you do not, and the thing about it is that oftentimes you want to make sure, and this is where family history is important. It's not normal, but you also may have a hereditary tendency. So if you know that there's a family history of kidney disease, whether it's, polycystic kidney disease or IgA nephropathy, or, they're not necessarily familial, but you also want to make sure that each generation is not at risk from that standpoint. So I'm not a pediatric nephrologist, so don't hold me to any of these numbers.
Oh, no. And it probably was a bad question to ask you in the first place, but yes. we do know that it's got to start with our young kids.
Yes.
Even if it's a small percentage, because when they get to adulthood and they've got this, you can look back. I think I probably had it a long time before I was actually really diagnosed. So,
right. And it matters. It matters that we as parents, that we educate our society to take better care of ourselves and to understand that this is important. Just as we condition them to always wear your seatbelt to save your life, we need to be conditioned to the sense that we need to make sure we get our annual checkup and our annual blood work. I tell people we've gone through a year of COVID. And during that year, I doubt so many people missed their blood work because they didn't go to their doctors.
Oh, yeah.
Who haven't gone to their doctors. So it's like, okay, now we're going into the second year. Get your blood work. Make sure, even if you can't go to the doctor's office and you're doing a virtual visit, have them send you a slip or call it into your lab, your nearest lab, so you can go get your blood work done.
Yeah, you want to get that done too before, as if people are listening, try to get that done before you have your doctor's visit. Get the order first and get that done before the doctor's visit.
Right.
Okay, so I want to kind of do a little circle around here. In your beginnings, when you started doing surgery, was it mostly with pediatric transplants, or did you do? Were you on the rotation where you just did transplants? Period.
Yeah, we were at University of Pittsburgh and also jointly with Children's Hospital of Pittsburgh.
Okay.
So we got to rotate on adults and kids. And my interest actually in going to Pittsburgh was to do research to become a pediatric surgeon. So I was interested in pediatric surgery. So I tended to gravitate to the pediatric transplantation.
Yeah.
And to work with those surgeons because that was something I was interested in initially. So a lot of those of us who were training had no interest in pediatric transplantation, it opened up a door for me to be able to do most of the rotations that the others didn't want to do. So that became a focus for me early on.
You got well schooled.
Yes.
So we have a couple friends in our support group. I have a couple friends who've been transplanted later on in their life, and they actually have had pediatric kidneys placed.
Yes. Yes.
Tell me about placing a child's kidneys in an adult. How does that?
Absolutely. I think it all depends on the size of those kidneys, because you have to imagine I have to say probably the smallest ones I might have used were a 6-month-old. And because they were small, we usually call them like lollipops because they come together and you have to use they come on a common vein and artery that we use, which is our aorta and the vena cava, but they're so tiny, they're smaller than the size of a renal artery in an adult. And so we use those generally together. Oftentimes you have to think of a patient, the smaller the kidneys, the more work they're going to do if the body is too large.
Right.
The advantage that we have is that pediatric nephrologists, because of the complicated technical difficulties of sewing in these pediatric kidneys, they did not want them in pediatric. It's very hard to have pediatric nephrologists who have control over which kidneys you put in their patients. They wouldn't let us do pediatric kidneys in pediatric patients.
Okay, all right.
They're very complicated. They often may not work immediately. And so they did not, it's terrible to put a kidney in a child and have it not work.
Oh gosh, yes.
They wake up expecting the best. So generally they put them in young adults or small adults because of size, and you don't want those kidneys to hyperfiltrate. You're sewing both of them in, and generally on one side, you have to, because they're on a stalk somewhat, you have to make sure they don't torque and twist and get lopsided.
Get tangled up.
Get tangled up. So it's tedious from that standpoint. You have to make sure they are positioned in the correct way, and you have to sew both of the ureters and the drainage tube into the bladder. But these kidneys can work and can function. Takes time to grow and get larger. The increase or the improvement in the creatinine is much slower. So with an adult kidney, you will see your creatinine come down 1 to 2 points a day.
Yes.
With a pediatric kidney, you will see that improvement only in a 0.1 to a 0.2 difference per day, because they're so small and they're going to take time to really filter the body. So you don't want to put a pediatric kidney of a 8-month-old, a year-old donor into a 300-pound man. That's
no way. Yeah.
From that standpoint. So you do have to choose your recipients with good vessels and also small body size.
What kind of kidney disease in a pediatric patient? What necessitates a transplant? What kind of conditions will foster the need for a transplant?
Generally, for the younger kids, it's usually congenital abnormalities that happen in utero. Either the kidneys infarct or have lack of blood supply, so they're born already abnormal, agenesis, they fail to develop normally. And so for them, right off bat, there's very little to poor kidney function. The difficulty in in newborns is you have to get them, you have to support them so until they get to a size of about 5 kilograms, usually about. So you want them to gain weight, so you have to do 2 feed-ins, because the smaller they are, the smaller their blood vessels are. And the smaller their blood vessels are, you have to, if you're having an adult kidney, generally if you have a pediatric patient and you're placing a kidney from one of the parents who are now, you now got this newborn with after 3 months, because remember, without kidney function, they're not going to grow. So you have to supplement them to really cause them to gain weight. You may have to do peritoneal dialysis to help get rid of the waste products, but you have to give them all these calories to get them to gain some weight and to grow, so that they are able to then successfully undergo the surgery at a time when their blood vessels have now enlarged enough for you to be able to make these connections, because you're now connecting this adult kidney generally from a parent into this small, 1-year-old or 2-year-old, depending. Sometimes it takes a while for them to gain 5 pounds. And so if you imagine that the whole blood volume of that child can be in that kidney once you unclamp.
Oh, yeah.
And so generally in that situation, you have to make sure that the child is can tolerate the low blood pressure. Remember, and when you're putting a kidney into a child who has a blood pressure of 80/40 normally, and now you're putting a kidney in there, but that 80/40 of adult kidney is not good enough to make that kidney work.
Yeah.
Because it's so big and it's sucking up all the blood volume of the child. So those are the challenges that you have to deal with. But once that kidney works, it's bigger than the size of usually you stuff it into the child's abdomen. And 12 hours later, that child will have normal kidney function. Because
12 hours later.
Just usually overnight, not even 12 hours. So usually by that night, the creatinine is 0.1.
That's amazing. I sitting here listening to you talk, and part of my career as an RN was working in surgery. Mm-hmm. And I cannot imagine how small, how delicate those vessels and all those structures are. I mean, we're talking peanuts or less than peanut size.
Yeah. Like if you imagine, if you look at your hand and you see a vein, a vein on your hand, sometimes in a small child, the aorta may be that big.
Oh my.
So you're trying to sew something. So you want that child to get bigger, because now you're going to suck all the volume into that kidney. So you have to be able to support it. And then that kidney may not see enough blood flow. So that's the one thing about getting the child larger. So they now have a slightly more greater blood volume to be able to allow that kidney to work well.
This may be weird. Did you ever have to transplant twins?
No, we had, I know we had a situation where one twin had kidney disease and was in need of a kidney. The other twin was fine. And it was unfortunate because growing as teenagers, before the one twin got to the point that he really needed to make a choice between dialysis or transplant, they needed renal replacement therapy. They were misled by their doctor with the understanding that because they were identical twins, one, at age 12, well, your brother would be able to give you a kidney because he's identical.
And that's not true.
They're underage.
Underage. Okay.
So yeah, even though he might, you cannot take a
minor's kidney.
their minor.
I
A
never thought of that.
parent can't take a minor's kidney to give to another minor.
Sure. Well, that makes sense.
So it's like, no, that's not going to work.
Well,
Wait till he gets to 18, then he can do it. In the
and then he's got to agree.
Right.
And then he's got to agree, right?
Yeah. So one of the parents had to donate for first go around and wait until that however long. You figure it, the kidney's not going to last forever. That's one of the patient's kidneys are not going to last forever. So when the time comes that he needs another kidney, then if the identical brother is without kidney disease, and this is one thing you always have to watch out for, identical brother, to make sure they're not at risk for the same thing.
That's just amazing. So as we look forward now to being a teenager or getting into early age, there's a lot more people that get transplanted at that age than there are, with younger kids, way like infants and even newborns. But do you see a lot of teenage now in your practice or in your instruction? Do you see a lot more transplants going on with teenagers, younger people?
The advantage of pediatric recipients is that they get extra points if they're under the age of 18. They get extra points along the way if they're under the age of 12. So the younger they are, they get extra points. The goal is that kids need to be transplanted in order for them to continue to grow. So the younger they are, the goal is to get them off the list. You want to really push the living donation situation into kids, get them off the list, get them to be normal, because the longer they wait on dialysis, the more they're going to lose in their growth spurt.
Right. That was what had always bothered me, is how in the world does kids will actually grow, because I've had friends with have had 4 or 5 kidneys and they don't get much more than 5 foot tall, and they're just sharp as tacks, man. Some are brilliant, and it's kind of a tightrope for you to have to plan for those transplants, because once you've had one, it's not going to last forever. I hope mine does, but anyway, you have to think ahead. And so do you think a lot has to do with how well you do take care of yourself?
Absolutely. I think, the issue that we have with teenagers and young people is that they want to fit in. Mm-hmm. They want to be normal. They don't want to be seen as different. And having to take all these medications every day makes them different. So we have the biggest issue with teenagers and young kids who wants to get past the point where they're no longer being supervised by their parents. So now he says, you're old enough to be able to take this medication on your own. And with any kids, even if it's not transplant patients, with any kids who are on medications, it's a chore to get them to remember to take their medications. And they often are not truthful about taking their medications.
Yeah.
That's the downside. That's the downside that we see. We're dealing with rejection a chronic rejection, because they're more likely to miss the set of medications and not think twice about it, And so that monitoring and that diligence is one of the struggles we have with the kids who say they're responsible for taking their own medication and getting them through the teenage years. So there's always a big debate of a kid loses his kidney from the non-compliance. Do you transplant again when they're still in that age of not really taking that responsibility, or do you wait until they get older? But then so that's all. How do you teach them that this is an important thing to do?
Because the only other alternative other than the transplant is dialysis. So, and that's a struggle at teenage,
Yeah, but oftentimes many of these kids are done preemptively and have never had dialysis.
Exactly.
They don't know the experience of dialysis.
Right.
They don't know what it is to be on dialysis. So that also the if you've been on dialysis, you're like, I don't want to go back there.
Nope. Nope.
You don't want to do that.
So that brings us back over into the living donor, the idea of living donation. And I know that you're an advocate for that. I know you tell me a little bit about your feelings on living donation. How important is it? Because it doesn't happen very much in this country.
It's the way to go. It really is the way to go. You can, number one, the best ideal situation is to understand that you need a kidney and be able to find someone, not necessarily a relative, but find someone who's willing to give you that gift and do it before you hit dialysis. A significant number of people are told when they have kidney disease, well, you're going to be on dialysis. You're going to have to think about starting dialysis. We need to change that narrative. Get rid of it. Push it out the door.
Yeah.
I know dialysis is a money maker, and that's how folks get. It employs people, and people make a lot of money off of dialysis.
Yeah.
But for the patient, the best thing is to say, early diagnosis, find a donor. We need to change the narrative. People think kidney disease, get on the list. Kidney disease, living donation.
Yeah. That's what has to happen.
Be secondary. Find a donor, exhaust your possibilities, and only then will we think about getting you on the list. Because people have that fallback of, I've been on dialysis 12 years. I can get a kidney sooner. That's true.
Yeah.
It made the quality of a living donor kidney who has gone through all the workup is not at risk. It's going to work immediately 99% of the time. That it doesn't have the underlying chronic issues because we don't take a kidney from anybody who's diabetic. We don't take a kidney from anyone who has significant 20 years of hypertension. Those things don't exist in the living donor realm. So their kidneys are much better quality. And so you can have better longevity, barring the issue of rejection and antibodies.
Right. I think that you hit it. At some point, the community needs to look at saying, let's prepare for transplant, not prepare for dialysis. And I think that's the standard that ought to be. And
Yes.
you just said it so eloquently. There's no reason for you to not search out a donor. I don't know of any reason for it. Being,
But
the sooner the better. The sooner
it's not the norm. If you need to make it the norm.
Exactly.
That has to be the words out of your mouth. And it's interesting because when I speak to colleagues who invite me and talk to people in the UK, that's the way they think. Oh, I was just diagnosed with kidney disease. They told me I have to find a donor. I must find a donor.
That's true. They don't talk about preparing you for dialysis. It's let's do the algorithm. Well, how many are your parents? Are your brothers? You got sisters? You got cousins? You go down the list, and do you have friends? Where's your connections?
Yeah.
Do you have getting out of the mode of, well, I couldn't ask for that. Well, that's why what we do at Kidney Solutions, we try to get them to realize that if you don't ask, you're not going to get it. Nobody's going to be able to pray for you if they don't know. So,
right.
Yeah.
Right. So,
I think that's that mantra, that ability to look at transplant first has got to change, like you said. What do you think? What do you think has to happen? How do we change that talk?
By constantly putting it out there so that it's on people's radar.
Okay.
Just like we say, we automatically associate high cholesterol with heart disease. We need to associate kidney disease, kidney failure with transplant. That should be, when you do, it's almost like you do a search in the Google, you put in end-stage kidney disease, everything about, how to find a living donor, solutions for kidney transplant. We have to continually inundate our industry with thinking about, and that's one of the things I was talking to our transplant coordinators. It said, the first thing you should do when you begin to educate patients coming in for evaluation to be listed is to change that. You're not coming here to be listed. That's not your primary goal. The primary goal is that your chances of dying on dialysis are greater. What are the chances of you being alive on dialysis in 5 years? Your chances of getting a kidney and keeping alive, that's what you want to do.
That's exactly right. And I heard it best said, you know, instead of bringing your wife to your evaluation, bring a potential donor.
Right.
There are hospitals that allow that to happen. They encourage you right off the get-go. Bring a donor. If you have people that want to test, bring one. We'll test them.
Right. You're coming here to find a potential kidney, but look in your own backyard first.
That's right. Get in the backyard and scurry around. Make sure you're asking everybody, you know.
Right. And if you don't know how to ask, then you have to come up with, then we will teach you how to ask. And that's
right.
That should be, you're here to find a donor. We're here to help you get there.
Right. Exactly. Yep. And that's the most important part of this, other than getting it early. You know, when somebody shows up in stage 4.5 to 5, you know, it's going to be much more difficult.
And that's, unfortunately, where so much of the underserved population end up in the emergency room, being diagnosed with end-stage kidney disease and being told, I'm going to have to start you on dialysis tomorrow.
Right.
Because that's the only solution at this point in time.
Yeah.
Because you are in acute kidney failure and chronic kidney failure with needing urgent dialysis because you're so far down the line.
Right. You're past the point of no return and we got to get you back. Yeah. The idea of screening has always fascinated me in my nursing career because it pick up a lot of things. And there are organizations that are doing some screenings, especially in lower income areas and less served areas. And I think there should be a change. There should be a change to take a look at doing more of that in communities. That ought to be it. Not waiting on it to figure it out that the doctor says, oh, you got kidney disease. You've got some things that you can do in there, like you said, creatinines, and blood pressures, and protein in your urine. So those screenings are important.
If you think about the hundreds and thousands of kids who need exams to go back to school, adding a simple urinalysis to that school exam, or even just a dipstick to say,
yeah, that's it. That's all it takes.
I want to check for protein.
Yeah, yeah,
yeah. That would make a difference in those kids who get diagnosed early.
Because those kids are going to grow up to be adults, and when they grow up to be adults, and they got kidney disease, you go and you look back and you say, "Wow, what did I do wrong?" Well, you didn't test, you didn't screen, you didn't look.
And oftentimes, so many young people that I see who come in being evaluated, and I said, "When did have you ever had any history of protein?" And they says, "Well, you know, maybe when I think maybe about 10 years ago, somebody mentioned it, and that was it. It went back, and I was supposed to follow up, and I never followed through." And the story, there's that story.
Yep. And plus, I don't have the money to go. I don't have the insurance to go. I don't have the ability to go see a doctor every time a little something happens. Right. And it's serendipitous. They happen to be in for something else, and it shows up. So yeah, I agree. So I think we got it figured out, right?
Yes, absolutely.
Yeah. So what role does the nephrology community play in this early diagnosis? Is it in your opinion, do you think it's best to do that in the med schools, or even more so earlier on than that?
I think earlier on that, I think one of the things that we fail to do is general practitioners need to play a much more active role in early diagnosis and referral. I hate the terminology, well, your kidney function is getting worse. That's what I was told about my dad. And he goes, worse than what? I mean, you mean it was bad to begin with? And when was it bad? And why did I not know about it when it was bad?
Yeah. Yeah.
And so, well, it really didn't really see it as a problem because, no, some problems get worse. So recognizing that a patient is at risk and not belittling the situation or not sweeping it under the carpet to say, well, just a little bit of concern. Let it be a concern. Let the patient know about it. Let them know that this is important to follow up with, because many patients walk away from the doctor's office not even knowing what they just said or even understanding the results of the test. And so I think it is upon us to empower our patients and our community to say, get a book, get a notepad, get something where you get your own copy of your lab work.
Right.
Get your own records.
Yeah.
Write down everything the doctor says. Go to the doctor with a list of questions beforehand. Think about all the questions you want to ask them before you get there.
Right.
And if you're going out the door, say, wait, doc, I didn't get to question number 3. Make sure you get your questions answered and make sure you leave there understanding what the doctor said and understanding the issues that you are facing, if there are any issues that are important for you to follow through with.
Yeah, and that the chit chat in the doctor's office doesn't do the patient any good. How's the weather you doing? How are you doing? Well, you got to have something in your hand to force the conversation, because there's such limited time available.
Right.
So if you go in with 3 or 5 questions or 10 or whatever, but prioritize them. Make sure you're getting to the point right off the get-go, right? Because half of that time is going to be evaluating you by putting a stethoscope on you, doing an abdominal exam. Anything that requires time consumption takes away from your ability to ask questions. So don't talk about the weather and don't talk about your kids and all that. That time is your time, right?
Yep. You're paying for that time. Make sure it's worth it.
That's right. That's right. That's right. Well, we didn't go in circles, I don't think, did we?
I don't think so. No.
Is there anything that you would like to get across, make a point of, or something that you really would like to discuss before we close it off?
Well, one of the things that I wanted to tell patients that it's important to know your family history. Sometimes families don't talk about it. You have to make sure you understand your risks and who in your family history have problems that you may be likely to inherit or be at risk for going down the same path, so that you can have that knowledge and understanding and start early. My mother was diabetic, my father was diabetic, or this person has kidney disease. Let me make sure. It's important for me to make sure that I'm not at risk for those same things. And I think it's important to have that discussion with your doctor, understand your numbers, and let your creatinine and protein, add those to those things that you need to know. Those are your know my numbers, not just blood pressure and blood glucose and your weight and your cholesterol, know your kidney function as well.
Absolutely. And that's the terminology you can use. What is my kidney function?
Yes.
I mean, that's the biggest and the easiest way to explain it. You don't have to talk renal. You don't have to talk, you just say, what's my function? How are my kidneys doing?
Yep, absolutely.
And I think that picks the interest. Okay. I could go on all night, but I think we're both at the end and you've given us a lot of good information. And I look forward to seeing you in Clubhouse and down the road. And I would like at some point time just to thank you really from the bottom of my heart for coming on. Great information.
Thank you. Thanks for having me. This was fun.
Okay. If you just stick for just a second, I want to close it up, and then I'll just want to talk to you just a little bit, just a second. All right, folks. You heard it. One of the most intriguing things about kidney disease is you may not even know you have it. If you want to know, you got to ask, and do like Doc says here, get your protein checked in your urine, get a urine analysis, and ask what your renal function or your kidney function is. And in the interim, make sure that if you do have a diagnosis of kidney disease, you take responsibility for it. You know about it, you learn about it, you ask people about it, you ask your doctors, but don't just go willy-nilly and just take waiting out of your vocabulary. Waiting shouldn't be in your vocabulary. Take it out. You need to stress to yourself that you're going to take care of yourself and you're going to find out what's going on with your kidney disease. Other than that, the next time we talk, we'll find somebody else who's really interesting and we'll bring them in. And until that time, keep breathing.